Thank you. And so I'm here to give a little bit more of a perspective on the effect of emergency declarations and where that impacts pharmacy practice and public health. So if I could have the next slide. I'm going to highlight a few things, not the least of which is the state emergency orders that can affect the Pharmacy Practice Acts, but also the PrEP Act, which was essential for H1N1. When Mitch showed you the ASCO framework for collaboration of pharmacies for H1N1 vaccine, the PrEP Act declaration was absolutely an essential piece, because when we brought representatives from pharmacies into the room, one of the first questions was in regards to liability, and having that PrEP Act declaration just took out what in other times would be months of negotiations in regards to getting the goal that we had, which was getting flu shots into people's arms and noses.
Aaron, let me interrupt you and say, if you're not familiar with PrEP Act, HHS has a web page. You can go and look for that, but it really specifically deals with protection for liability for those who are handling countermeasures that have been stockpiled by the federal government. So vaccine.
But it's not specifically only related to stockpiles. It can be, but it has the authority for any stock that is out in the open market, and it doesn't just apply to pharmacy. It applies to manufacturers, to distributors, to planners, the whole realm of who might be involved in decisions as far as getting a medical countermeasure into someone. Tied in with, but the nuance to pay attention to in regards to the PrEP Act is that it often requires a federal disaster declaration. At minimum, it requires the HHS secretary to declare an emergency, or to declare the likelihood of an emergency. Is that the best way to say that, as far as that's concerned? So, you know, there are some definite nuances as far as when that authority can be pulled out and when it does get pulled out. You know, one of the things that we did not see during the initial part of the H1N1 response was that federal declaration of emergency. That didn't happen until September. And so there were a lot of tools that we might have used that weren't able to be used as far as that's concerned. So just, you know, some caveats as far as, you know, depending on an emergency declaration, we have to also be very careful and examine what those triggers are, and make sure that if we are moving towards the goal that of public health, that we need to make sure that those triggers get aligned as well, because otherwise, you know, those authorities aren't there, and the assumptions that we maybe made, some of our plans weren't able to be implemented. And it definitely was something that we saw during H1N1. Emergency use authorizations are a big tool as well in regards to the federal piece of regulation. In particular, they affect pharmacy practice in regards to things like being able to extend the expiration date of medications, which again, during H1N1, we saw a lot of confusion and questions about. There were questions from state boards of pharmacy saying, wait a minute, you know, this really, you know, you can't dispense something because that's really misbranding as far as that's concerned. And of course, pharmacists were also very concerned. Wait a minute, you know, you're just telling me it's okay? Can you give me some proof? And that wasn't forthcoming and what have you. So communication in regards to these authorities ahead of time is also very essential. Not just expiration dates can change indication. So, you know, what age group medication is approved for, or even medication that isn't approved as of yet could be utilized during the time of disaster. All of that kind of information is very essential as far as pharmacy practice, and is an essential tool that has been used and will continue to be used moving forward. I mean, we just saw an emergency use authorization approved for H7N9, correct? For a rapid test for that just last week, I believe. So, you know, it is a tool that is still being utilized, and it's very important. And that communication about those tools to people who don't normally think in this realm in regards to disaster preparedness. That's a level of communication that maybe hasn't been handled quite so well in a lot of areas. State emergency orders, we're going to talk a little bit about some of the collaborative practice agreements, going back to where Mitch left off in regards to some of the barriers that the normal practice, collaborative drug therapy practice, but state emergency orders can change a lot of things. During H1N1, the state of Florida had to implement an emergency order, state of emergency very early because they had pedigree requirements for their pharmaceuticals, and the Strategic National Stockpile didn't fit the pedigree requirements. So in order to be able to utilize that product, they had to declare a state of emergency in order to be able to utilize that product. Yeah.
Folks may not understand what pedigree. Pedigree
sorry.
basically is you have to be able to show how the product has moved through the system.
Just like you would track and trace hazardous materials, pharmaceuticals are, you want to make sure that you don't have counterfeit product. And so Florida, this is where I'm from, Florida being the poster child for drug diversion in more ways than one. It has very strict rules, which are being preempted now by FDA track and trace. But even so, sometimes there are state rules that have to be examined in regards to making sure that you can implement the plans that you want to implement. Scope of practice, something that's been alluded to. The great state of New York already brought up. So they've changed the immunization laws as far as what pharmacists can provide, both with Hurricane Sandy, allowing pharmacists to provide tetanus immunizations during the emergency period. And then the following January, looking at a surge in influenza, said pharmacists, expanded the scope of practice for pharmacists to be able to provide pediatric immunizations as well. And so, there's definitely some ability to affect what it is that the pharmacist can do to help meet the needs of the emergency as far as that's concerned. And then, of course, there is the potential, as we've been talking about, is that collaborative practice agreement. So the last square that I have there is the NABP Model Practice Act. I want to just draw your attention to a tool that is available. I've pulled out on the next slide a couple of the things that are, NABP stands for the National Association of Boards of Pharmacy, and they have a Model Practice Act that gets reviewed on an annual basis. There is actually a chapter for emergency preparedness and public health. And in that chapter, there are a couple of things that are directly relevant for this conversation as well. So if your state is one where there are some issues that may be addressed, this is a resource that you may be able to turn to look at implementing legislation to facilitate the goal that you might have in bringing pharmacy in line with being able to enter into that collaborative practice agreement or enter into your public health vaccination or treatment plans. So Section 3, for example, the emergency prescription order, and obviously I've edited and done some highlighting. All of the bold and italics are my emphasis. But so, for example, there is language in there to say, there could be pharmacists may dispense a prescription drug pursuant to an emergency prescription drug order. It gives some qualifications on what those requirements might want to be, but that's a great starting place in regards to looking at legislation in states where that might not be available at the moment. And then Section 4, looking at public health emergency refill dispensing, it's titled refill dispensing, but then if you look down into the Model Act, it says that the pharmacist may initiate or modify drug therapy and dispense what's needed to help take care of that patient. And that's another powerful tool that may be of use during a disaster, during a pandemic, to help make sure that patients have access to the antivirals that they need. And then, In addition, there is a provision added in there about the liability piece. So, you know, if you're following the guidelines that are coming out from your state health officer, from the CDC, you know, ideally you wouldn't want to be, you would want the pharmacist to feel confident that they are able to follow those guidelines and not be personally held responsible if it turns out that maybe we didn't have the full information that we needed in order that we were acting on the best information we had at the time. So that's an important piece as well. You know, not just the PrEP Act, but also state provision to help protect would be ideal. Let's say that. And if I could have the on the bottom of the slide, there's a link to the Model Practice Act if you want to read through the further details of that. It also has some information for mobile pharmacies, which could also be relevant in regards to some kinds of emergency response. So just to give you an idea of, you know, rather than doing the slice and dice as Becky did, just to kind of give numbers, I just kind of want to give you an idea of how many states have some of these collaborative practice laws that could hinder emergency access, and this is taken right from Mitch's list of 4 things that can be hindrances. So the first one to highlight is the requirement for the prescriber's initial diagnosis of the patient. So and as Becky said, you know, remind you that these things are in flux, and I think it is already out of date. As far as in particular, Becky pointed out to me Arizona, but just to keep in mind that, you know, these are the kinds of things that you need to be looking for in your state laws if you're not familiar with them. So requiring the prescriber to actually have the initial diagnosis, obviously, that's taking away from the pharmacist being able to look at the patient and evaluate them, and taking away from the goal of getting the pharmacist to be an extender and helping with the surge of demand for medical care.
Well, I mean, if the pharmacist is the prescriber, then aren't they making the initial?
They're not the prescriber under a collaborative practice agreement.
And you guys think that this is often used through with chronic disease management.
Right.
Okay.
So
Right.
this is for managing. Often the vehicle of collaborative practice agreements were envisioned to be originally for the management of chronic disease. I think some very progressive states have also then transitioned into what can pharmacists do for public health. And I think that, you know, certainly Washington State's my poster child for
Yes,
that. But,
everybody.
but I think that you just have to understand how the dialogue begins as to what pharmacists needed to really help the state to do. And chronic disease was the buzzword that most of them were crafted to try to address. And at that point, you know, it was envisioned that the patient would already be diagnosed with diabetes or hypertension. And the pharmacist would be doing all of their work in the management of that patient that had already been diagnosed.
And when these discussions first started up, I mean, initially, discussions were, can pharmacists initiate, modify, and monitor drug therapy? And based upon the politics and where things go, it gets whittled down from there. But for the perspective of pharmacists being recognized as, quote, the prescriber, and we've gotten this interpretation through for immunizations, is that the protocol arrangement places the pharmacist as the prescriber, which then opens up the door for them being involved in the BFC program, because you have to be a prescriber to be a part of the BFC, and we've got CDC's legal interpretation is through the protocol arrangement that has given them prescriber tag that allows them then to move into the BFC program. So, well, on one hand, it doesn't make them a prescriber. The authorization does put them in a situation where they could be in an authority position for access to services.
So, not to spend too much time on any one detail, just to kind of show you the geographic spread, and then moving on to the next, the requirement for a physician order for therapy for a specific patient. So this is where I think, as public health, you might want to think specifically about that a protocol. You know, can you write a protocol for all the patients in your state? that would meet the requirements for that law. And, so that's something to take into consideration as far as moving forward.
And that's a major challenge for our pharmacist practitioners, is to identify a physician who will enter into a CPA agreement. Some have been very successful, some have had challenges, but where we've seen successes is when the local public health department medical officer is willing to enter into that agreement, because then you take away that potential barrier of having to go to individual practitioners to do it, and you can bring a bigger critical mass of pharmacists being able to do this and under a consistent protocol, which is the other thing too that you want to try to do, is consistency for the patient interaction.
Yes, absolutely. And again, when those state emergency orders are implemented that change what the pharmacist is allowed to do, they still then have to go back to the medical their medical provider that they have the agreement with, in some cases, to amend that. And so that's another just potential obstacle in getting access to patients as quickly as possible. So the next one, the requirement that collaborative drug practice take place in a hospital or similar facility. You can see that that's not a huge number, but it's still not insignificant. And then the next one, requirement that the pharmacy have a private setting for the collaborative drug practice. So as you can see, if you look at all of the states where there is at least one potential hindrance, it covers quite a bit as far as that's concerned. So, but a lot of states where we have much more lenient, much more ability to work around, that's where you've been able to see a lot more movement as far as that goes.
So let me ask the panel, I'm looking for you. So let's say that we really want to engage the medical directors of each of the poison centers that might be able to do this triage line. What action can you do in advance of an emergency, knowing that maybe your state has one of these barriers? Who is there something written that shows the override during an emergency, or is this the state attorney general's opinion that needs to be sought, or what can be done ahead of time to understand, what barriers are truly going to exist?
Well, I think the start is to look at the individual state law and find out if the state has a specific statute that deals with emergency situations that prescribe the process and what can or can't be done. For example, Beck, you want to talk about Ohio?
Ohio. Yeah, so some of the emergency, I think there are a couple of things. I think specific to what Mitch brought up, in some of the states, such as Ohio, their emergency authority does not allow to go beyond the current scope of practice. So it links back to the scope of practice. So they can declare that perhaps, for example, if in Ohio a pharmacist can provide influenza vaccine to patients 18 and older. If there was an emergency, then they can remove the barrier that I need to have a collaborative or a protocol with the physician, and the state can issue that protocol, but I still can't go beyond that 18-year-old level. In contrast, in New York, their emergency authority said, we have the authority to amend scope of practice to meet the needs of the population that's at risk. And they said, you can go down to age 6 or whatever it is that you want to, even though the statute says that pharmacists can only administer to adults 18 and older. And so there does need to be an analysis of what the emergency provisions, and if there are restrictions that we need to try to address in advance, or either develop workarounds. So in each state, you would have to look at what your emergency provisions are. But I think we also have to recognize that a lot of what we might want to accomplish is going to be in a time frame before an emergency is declared. Mm-hmm. And in that case, and with all due respect, because I live and breathe collaborative practice agreements, mostly for chronic disease management and trying to get all the states to not have shading anywhere there is shading now. No shades, no shades. But when I'm thinking about a public health emergency, I really wouldn't link back to collaborative practice agreement. I'd look at the prescriber's scope and what they can delegate. And I think most state prescriber laws are extraordinarily lenient as to what they can delegate. And just as was identified in Minnesota, I think that that's the lens that we need to look through this rather than tying ourselves to very clunky collaborative practice laws. Because quite frankly, if I had to do it all over again, the last 20 years, pharmacists would not be trying to pass state laws to provide collaborative practice, because I think it's just restricted us rather than liberated us. I think the states that have the most liberal view don't have any laws in place, and it's just interpreted that you can meet the needs of patients. And so I think I've said this 5 or 6 different ways, but I just would throw CPAs out of the discussion, and it's not useful. It's just not going
And
to be
just to add
helpful.
on to what Becky said, a lot of states allow the physician to delegate authority to whoever they would like. So looking at it from the states, see what a physician can delegate is a great recommendation. What we find is states that are silent, nobody raises a stink until somebody finds out, that because a physician may find out in the community that something's happening. And all of a sudden, they're calling the Board of Medicine or the Board of Pharmacy, and that's where then it starts riling up people. So it's, ask for forgiveness. In a situation of emergency, it's ask for forgiveness. You're trying to serve the public. As long as we're keeping the public centered, I think we've got a good case to defend against it. But I would say, though, making sure that the Board of Medicine and Board of Pharmacy are aware of what you're going to be doing will help save some headaches down the road.
And have the Board of Medicine and Board of Pharmacy have some emergency provisions, as Erin indicated, that's in the Model Practice Act. There are things that we can do now to do an evaluation, see where they are, see where they aren't, and really look at it through the lens of emergency and public health versus...
And the other thing, too, is to let the medical community know what you're doing, so they don't think you're going to be making this an ongoing, everyday occurrence, that it's only going to be implemented when it's an emergency. If you take away that fear that, oh my gosh, now I got to be worrying about the poison centers or this one who's going to be taking away my patients. That's the concern we all have to deal with in the medical community.
All really very important parts. And just to let you know that NACHO is working on a toolkit for state and local health departments to be able to understand the complexity of the conversation we're having, what some of the tools are, some of the action steps. And so at the end of the day, I'm sure Amy and Sarah want to say something about that. So I'm going to close the panel. I think it was an excellent discussion. Thank you for the speakers. And turn it over to you, Sarah and Andrew, to reorganize us for lunch and the next session.
So I think it'll be a couple minutes until lunch is here, so maybe,
We can take a couple more questions then?
yeah, we can take
Okay.
a few questions.
Okay. I know a couple people have to leave right at noon, and if you do, we enjoy having you. I don't know if you can stay for a couple more questions. Okay. So, any questions for Erin, Becky, or Mitch on that last panel?
Good question. Great. On the states that, so it seems like on a lot of the allowed states that they're generally the same amount of numbers, like 30.
Yeah.
Is it, did those states vary widely, or is it general? Is there like a general bucket of more liberal states and then more across the board, or is it all over the place in terms of who allows this and not this?
It's a very good question. If you have 37 states that allow something, they're going to be part of the 45 states that you can do collaborative practice agreements. And that usually, if they're liberal, and if they're very restrictive, they're very restrictive. I've got 4 problem child states for immunizations that are extraordinarily restrictive, but there are only 4. But when you look at an analysis, there may be there may be, 46 states that can do this and 43 states that can do this and that. So all of the bulk of everybody can do everything. The same way with collaborative practice agreements, the bulk of them you can do everything. And I will say, last year I had, and this is the reason why I was not, I was just like, I was looking at Aaron's slides and I go, well, last year Virginia passed some legislation, the year before that Arizona passed some legislation. It's also a moving target. And so I think that you're going to see, like this year, I've got 6 states that have amendments to their collaborative practice provisions that are in the works, and so it's continually changing to meet needs. Originally we really looked at this through the lens of chronic disease management, but now we're there's. And whether they tie it back to a collaborative practice agreement or not is sort of a debate. But now the biggest trend that we see is pharmacists being able to assess and initiate naloxone in patients that they anticipate may have a drug overdose. And so there's going to be a whole wave of state laws, and some of them are going to tie it back to a collaborative agreement, and some of them are going to tie it back to a partnership with public health, and some of them are just going to say, you know what, pharmacists, you're out there in the community, you know somebody's using, go ahead and send them home with some naloxone because you can save a life that way. And so, I don't know whether I answered your question.
did.
I got off.
But we really do need to ask this question. So the 4 states with challenges are?
The 4 states for the immunization challenges, let's see how good my memory are. New Hampshire, New York, Florida, and in South Dakota. South Dakota, you can't do anything with influenza. You can't even do pneumococcal in South Dakota.
Kentucky is a challenge, but they require a prescription.
Yeah, and then some states are problems because they require prescriptions, but there have been innovative ways to get around that. But,
Other questions?
Yeah, one observation, most of the limitations on collaborative practice agreements are arbitrary and they're not rooted in patient care. But I guess the question I would have for Becky is if Washington State, the way that they've structured their collaborative practice agreements, and that was more commonplace among all the states, would that change your impression of how collaborative practice agreements should be looked at in an emergency situation?
yes, because and we've got experts from Washington, so I want to describe their law, but I don't even refer to y'all's even as sort of collaborative practice. It's more your authority under protocol. And so it's not that. It was never envisioned to be as restrictive to a panel of patients, if you will, where a prescriber has a panel of patients and I'm letting you manage my patients, of those patients that have diabetes, you can manage them. They can do that, absolutely. But they have such broader ability just under blanket protocols of public health.
Ours was the first, so everybody says that we probably wouldn't be able to push ours through because then everybody started watching and wanting to restrict and put their Me Too's in. And so I think we got away with having an open one because nobody knew what it needed to make it more specific. And so ours really does say it's an agreement between a pharmacist or a group of pharmacists and the physician, or rather independent prescribers. We can also have nurse practitioners sign off on our private practice agreements. And it allows the pharmacist to prescribe medication in a described situation. So it does have to say, what patient population, what situation, and what medications, and we leave it at that. So we have pharmacists prescribing medications for pain management. They have DEA licenses. We absolutely have the pharmacies, a number of pharmacies doing the take-home naloxone for people at risk of illness. We have pharmacists doing tobacco cessation training, back to yours, in different niches for different public health needs. And what I'd say is we don't have to look at just the restrictions of collaborative drug therapy agreements because it's, what do we wish in an emergency situation? I think that's part of what we're here to decide. But having those collaborative practice agreements in place helps pharmacists think ahead of what documentation do I need to have, what is required of me as a pharmacist. It helps it's the training wheels for getting providers on board and understanding the role of pharmacy in that situation. So it's important in terms of building a foundation that we can build upon instead of having it be this new thing with where is the authority coming from and how do I really do this? And gosh, I don't know. So that's my background.
That's the beauty of Washington State too. You got, pharmacists have to file that or send it into the Board of Pharmacy for somebody at least watching over what's going on.
Ours is actually not even approved by the board. It's just filed by the board.
Right, just filed, is what I'm saying, yeah.
So it's really open.
And another good example too is in the state of Oregon, for their immunization, basically
Their
authority
free
comes from their public health law, and that the health department actually has the protocols on their website for the practitioners to use, but they don't have to, it doesn't have to be entered into between a pharmacist and a physician, they just follow the protocol. It's
They
a
can
guidance.
prescribe a certain chunk of vaccines for, I believe, age 12 and older, a certain age group, and then they can get to all the other vaccines and all the other age groups if they have a more specific collaborative practice agreement on file. So they've blended the two models really well. I agree, theirs is great for immunization.
And I think the day-to-day practice of the chronic disease management is really a relationship between a private provider and a pharmacist, whereas we're thinking of this being part of the state or locality's emergency response efforts. And that's where some, I think, of the difference, sort of what Minnesota did.
Yeah, I mean, hearing the conversation, Minnesota, to my knowledge, does not have specific language about practice agreements because there's this broad ability to develop a protocol by a licensed prescriber that there's this whole list of people who can administer it. And so there isn't even a requirement.
It's more under the medicine laws to
Correct.
delegate than it is in the pharmacy laws.
That's exactly
to-
the way-
But that's really where the challenge comes in though, is if you go back and look at, and we haven't done this analysis, I should go back in like Minnesota or other states and say, while they've got that authority, how many practitioners are actually able to enter into those agreements? Because as we are hearing from our members, the challenge is getting a physician to sign the protocol. And in the situation we're talking about here is ideally if the public health department medical officer says, okay, I'm entering into an agreement and this will be implemented in an emergency. This is what we're going to do. That takes away the time lag of getting those put in place. I think that's what we should be shooting for.
I agree. And just listen to what has been said, it seems like an untenable approach, to try and sort through all of the myriad of different, arrangements that was so well described. It seems like the common denominator of the state health departments, state health directors, and, there's points of interface between, CDC and HHS with those agencies.
Absolutely, but the reason why we're having this meeting today is to really refine the discussion with them and to hone down what's really the ask, and to try to brainstorm with all of you, how that should be described and approached, because most of us, including myself, are not experts at CPAs, and that's why bringing you folks together is really, really helpful. So.
I wanted to say one other thing too. I know the focus of the discussion today is about pandemic influenza and antivirals seems to be a major theme. But I think about the other scenarios that this sort of leads into in terms of like a bioweapons attack, and just throwing out there that if it's not a national event, but it's a more localized or regional type of event, like a bio attack, there's a National Volunteer Health Practitioners Act that's out there that does describe, legislation that's been enacted in a handful of states in the district to allow for reciprocity of, health professionals such as pharmacists and others to come to a jurisdiction that's affected by that emergency, and it kind of clarifies a lot of the credentialing issues.
And Captain Tassad, I think, must have had an emergency or something, had to leave.
He had another meeting down the street, which he's coming back.
Okay. So, and the MRCs, are linked into that, absolutely. Thanks for your comments.
I just want to comment to come back to coming back to the state. One of the things that Mitch brought up was that having some sort of consensus agreement framework is really important, because when you're looking at a regional or a national company, signing agreements with 50 states and the DC and Puerto Rico and wherever else you practice is hard enough, but doing 2,900 localities is just impossible. So just something to come back to is if we can really build a consensus as far as what it is that we're looking for, how we want to accomplish it, and making that fit as best we can with the state laws, that would be tremendous.
Just to build on your comment, I mean, to make it even more practical, we have used this very, I wouldn't say routinely, but in the context of, for instance, of measles mass exposure, I have written protocols to allow for the administration of immunoglobulin to people that I don't have a relationship with. This has been used in the context of large exposures to hepatitis A and in a restaurant setting and a few others. So, I mean, we are using these kinds of things right now and find them to be really important tools, because the alternative is that you send 100 people or even 50 people or 20 people to their respective healthcare settings, and many of these interventions are time sensitive. So I think it's a fantastic point about how there is this much bigger context that these kinds of agreements can occur in, and we're very fortunate that our law allows broad abilities, but states may have under various practice agreements to take advantage of something similar, just using a different route.
Yeah, and it's also worth mentioning that there is a difference. With a bioattack, you would be doing mass prophylaxis to an affected population. But really, antivirals is targeted treatment, and that therefore you need that triage component to come in front, because not everyone really needs antivirals during pandemics, and the timing of it's really important.
One thing that,
And I would agree, I think the rapidity at which dispensing would need to occur for a bioterrorism event would be exponentially greater, leading to the word, well, for purposes of prophylaxis, but given the anticipated pandemic mortality associated if the terrorist is not retarded, would be really profound.
the project that the district did last year, the mass dispensing for post-anthrax exposure, mass dispensing still fell under the responsibility of the state and local government.
Yes.
But for the follow-on, the 50-day supply and the first ABA vaccination was really where the pharmacies, the retail pharmacies, were found to have a lot of utility.
Absolutely, and then backing that up, New York City is looking at a model of the time lapse between identification of an anthrax exposure and the time that pods can be mobilized. And there's actually a bare spot there. And so they're looking at their pharmacies in Manhattan and other localities stockpiling antibiotics to be able to rapidly deploy to fill that gap before those pods can open up. So there's roles for pharmacies all along the continuum of that kind of response. Why don't we do